vitamin D now. So vitamin D, what all do we know about vitamin D? Many a times you might be getting patients, who come to you for lethargy, fatigue, and then you order them a vitamin D, B12 hemogram. But do you really need to do it? And in that scenario, and so what all things can happen due to vitamin D deficiency, and where should we actually do a vitamin D level? That is what I'm going to talk about. So vitamin D, we know, is a fat soluble vitamin, and sunlight exposure is the major source. So 90% of our body's vitamin D is obtained from sunlight, and the influence of diet on vitamin D status is minimal. And vitamin D is important for the maintenance of bone health. So we need to understand many times that patients will ask you that if I eat this non-veg, or if I eat that non-veg, will I get vitamin D? So you might get, but it is very minuscule. So diet is not the major source of vitamin D. The major source of vitamin D will remain to be sunlight. Okay. And whatever role vitamin D has is only in the bone health. So when it comes to non-skeletal impact, so now we will be, because in this COVID pandemic era, you might have listened to topics of vitamin D deficiency and COVID outcomes. You might be listening to vitamin D deficiency and PCOS, or vitamin D deficiency and diabetes, vitamin D deficiency and thyroid. But all these non-skeletal manifestations, as we would call it, of vitamin D are not really proven. Yes, vitamin D, when given, might be good for immunity, might be good for insulin resistance, but we really don't know that. We don't have a trial where giving vitamin D is going to reduce your diabetes, or giving vitamin D is going to reduce your insulin resistance. So whatever vitamin D that we give as of now today is mainly for the bone health. Okay. And we can easily monitor the vitamin D levels by measuring a 25 hydroxy vitamin D. So when I write vitamin D, the lab measures 25 OHD. So this is what the lab is going to measure. Now, we get asked this question many times, that we say that sunlight is a major source, and India is a very tropical country near to the equator. Then why is still there vitamin D deficiency common even in sunny India? So, and the prevalence of vitamin D is very high. It ranges from, majority of the population is vitamin D deficient. Okay, in spite of India being close to equator. So, and this is what it was seen in this study published in Delhi. So in Delhi, what they have seen is that soldiers, who are out in the sun, practicing, exercising, and in spite of that, uh, their mean vitamin D levels was 18.84 nanogram per deciliter. And here I would like to emphasize that a value more than 20 is considered to be not deficient, and value more than 30 is considered to be sufficient. So 18.84 is low. So in spite of them being in the sunlight, still the soldiers had a very low vitamin D. And if you look at the physicians and nurses, they were the group who had the lowest, even lower than the depigmented subjects. So we are continuously sedentary workers, and we usually don't go out in the sunlight. And so we have very low levels of vitamin D. So that is what we need to understand, that vitamin D is very, very, very common even in those who are exposed to sunlight. Then also it's common. Even if they are exposed to sunlight, vitamin D deficiency is common. So the causes could be inadequate exposure, maybe because our melanin pigmentation is high, and that is why we don't make enough amount of vitamin D. Maybe because we are all become more sedentary and we don't have many outdoor activities. That may be the reason. Abroad, many countries do food fortification. So their atta or their milk or their breads, they will be all fortified with vitamin D. But we do not have such food fortification. Universal food fortification in India does not exist. And the last most important could be attire, because we generally Indians are fully clothed. We do not wear clothes which can expose our complete arms or legs, and so our the area surface area of the skin which is exposed to sunlight is actually less. So that could also be the reason as to why vitamin D deficiency is commonly seen in India. And as I've told you, the non-skeletal effects of vitamin D. So the current evidence strongly suggests that there is an association. That means, so those patients who are more vitamin D deficient will have a lesser immunity, will have more chance of developing a COVID, a COVID complication. But we do not have data to say that giving vitamin D is going to make them come out of COVID. So that is what I mean, that association studies exist, but it is difficult to reach a final conclusion because of lack of causation. So no study has showed a direct causative effect of vitamin D deficiency with other non-skeletal effects. Okay, so there is no particular vitamin D level. So we don't know that. So suppose if I raise my vitamin D to say 50, then I will not have any infection. I don't know that. So there is no vitamin D level for extraskeletal health. As against this, I know that if I keep my vitamin D beyond 20 or beyond 30, then I will not have any bad skeletal problems due to vitamin D deficiency. And whatever vitamin D that we give as of now is mainly for the skeletal health. So now, how do we diagnose vitamin D deficiency? As I've told you, what the lab performs is a 25-hydroxy D vitamin D. So vitamin D, which is, so from the sunlight, the skin forms vitamin D. This vitamin D has got two steps of activation. One is at the level of liver, the other is at the level of kidney. And the one which gets activated in the liver, that is what is called as 25-hydroxy vitamin D. And that is the marker which is actually studied in the lab. Okay, so when our lab studies vitamin D, lab studies both vitamin D2 and D3. Okay, and the common terminology D is used. So D2 is ergocalciferol and D3 is cholecalciferol. And D2 is, so in US, so if we see in India, what all we get is all D3. So all your vitamin D supplements which you prescribe to your patients contain cholecalciferol. Okay, but if you look at United States, then in United States, they do not have D3. They have only D2. So whatever prescriptions there they give will be of D2. Is there any difference between D2 and D3? No. So all for practical purposes, both of them are same and both of do the job equally well. So what are the levels at which you will say that a person is deficient? So less than 10 would be severe deficiency. These are the units which we commonly use. So I'm going to discuss the nanogram per ml, not the nanomoles. So less than 10 is severely deficient, less than 20 is deficient, 20 to 30 is okay, okay, not bad, but more than 30 is something which is preferable. Okay. So why do we arrive at this cutoff of 30? Why are we taking this cutoff of 30? So what vitamin D does is that vitamin D is, we know that vitamin D deficiency is not good for bones. Why is it not good for bones? Because in vitamin D deficiency, what happens is that the PTH hormone starts rising. So with vitamin D deficiency, the PTH hormone goes up, and we know what does PTH do? PTH acts on the bones, and from the bones it leaches out calcium. So PTH is ultimately making our bones weak. Okay, so because of high levels that are seen in vitamin D deficiency. So we don't want a high PTH, we want a normal PTH. So this rise in the PTH starts happening at this vitamin D level of 30. So when the level falls below 30, this incline starts happening in the level of PTH. And that is why you have got a cutoff of 30. And if you see below 20, so this is the 20 cutoff, below 20 there's a sharp incline. So 30 it starts rising, and below 20 there's a sharp incline. So we don't want it to be below 20 at any time. Right. So when should we order a vitamin D level? So whenever you find that the patient is complaining of bony pains, okay, has had fractures, is having osteoporosis, is having any musculoskeletal disorders. So now here I want to differentiate, want you to understand the difference between osteoarthritis and osteoporosis or osteomalacia. So osteomalacia and osteoporosis are two different conditions. Osteoporosis means fragility of the bones, where the bone architecture itself is it becomes brittle, or it becomes a porous bone. Osteomalacia is a more of a disorder of mineral problem. So, you know, the mineral that in the bone is wrong. So you might have a vitamin D deficiency, you might have a low phosphorus or a low calcium. All that falls under osteomalacia. In osteoporosis, what you have is that your vitamin D, calcium, your phosphorus, all may be normal, but still your bones are weak. So that is a different problem. That's the deficiency in the architecture, or there's a problem in the micro architecture of the bone. So that is osteoporosis. And osteoarthritis means something with the degenerative disease of the joints, which happens with age. So that's completely different. And osteoarthritis doesn't come under endocrinology. Okay. And musculoskeletal disorders. So like suppose if a patient is having say rheumatoid arthritis, so it causes osteoarthritis. The rheumatoid arthritis causes arthritis, but rheumatoid arthritis will also lead to secondary osteoporosis. So sometimes you can have a combination of the two conditions happening in one patient only. You can have chronic liver or kidney disease. So in those patients, they are very much prone to vitamin D deficiency, and you should do their vitamin D levels. Inflammatory bowel disease. So someone has got ulcerative colitis, Crohn's disease, chronic diarrheas, weight loss. These patients are more likely to have malabsorption and vitamin D deficiency. Then some patients might be on steroids, which can cause osteoporosis. Some patients could be on anti-epileptic drugs. These can also lead to vitamin D deficiency. So all these patients who have these underlying problems, you should do a vitamin D level then. Now, what are the requirements which are prescribed? So how much vitamin D should be given? Okay. So these are the US Endocrine Society guidelines, and this is what our ICMR suggests. So ICMR just gives you a blanket thing that 400 IU per day is what everyone should be minimally taking. But many times we have seen that studies have shown that this much is not sufficient. 400 IU per day really doesn't help you to keep your vitamin D beyond 20. Okay, so what is ideally should be given is that in the pre-pubertal or a pubertal age group, in the adolescent age group, 600 to 1000 IU. When the patient is pregnant and when she's lactating, then they require a higher dose. So 1500 to 2000 international units of vitamin D per day. In the toddlers and in the infancy, it is 400 to 1000 IU. In the childhood, it is 600 to 1000. And once you become old, then it is again 1500 to 2000 IU. So these are the different vitamin D requirements at different ages. Okay. And if you look at the calcium, how much calcium should a person be taking? So this is again the comparison between India and USA. So the guidelines differ as to what our ICMR tells us and what the US guidelines are. But we should remember one thing, that calcium we can also get it from diet. We need not always take it through a supplement only, but vitamin D is such a vitamin which we cannot get it from diet. So whatever that we get it is through sunlight and through supplements. Okay, so for infants, the calcium requirement is around 500 milligram per day. In the childhood, again, it is around 500. In the older age group, it is around 400 milligram per day. And in pregnancy and lactation, it is around 1000 milligram per day. So these are the rough calcium daily requirements which change throughout our life. Now, many times we ask this question, asked this question as to which calcium preparation should I use. Many pharma companies will come to you saying that, sir, ये calcium better है, ये calcium अच्छी तरह से absorb होता है, and all that. So actually, what is the truth? So the most common salt which is used in all the calcium preparations which is available now is calcium carbonate. And why is it the most common? Because it is a cheap option and it gets better absorbed with meal. So you should always tell your patients who are on calcium carbonate preparation to take it with meal. Okay, either before or after the meal, because it gets better absorbed with a meal. Okay, and if your patients are having acidity with calcium carbonate tablets, or they are already taking say proton pump inhibitors for acidity, then calcium carbonate may not get absorbed. So such patients who are on acidity drugs, they should be on calcium citrate. So our calcium citrate malate, the CCM or the Supracal Pro, they contain calcium citrate malate. Your Shellcal HD, your Tricem HD, and this Ciplacal and Cipcal and all those, these are preparations containing calcium carbonate. Okay. Our government supplies generally give the patient calcium lactate or calcium gluconate. So these are the least concentrated forms of calcium. So if a person has to take calcium lactate, then that person might need 4 to 6 tablets in a day, okay, of whatever is available in the government supply to actually reach that much amount of elemental calcium requirement. So that's why these are not really preferred. Now some people also come to you and tell you about calcium orotate, saying that it is a good supplement. So calcium orotate, yes, its absorption is better, but if you look at the safety studies, not many safety studies are available, and actually there are some studies to show that it might have some harm. So as of now, we don't really recommend calcium orotate. And please be aware of the natural calcium that, you know, some patients will say that, no, I don't want your artificial tablets. I'll take this natural calcium. I'll take that natural calcium. I'll take this calcium from this shell and from that shell. But we need to understand that all such natural calcium may be heavily contaminated with lead. So you might land, your patient might land up with other lead toxicity. So it's always better to know what you're using and to know what the content is. So please explain to this to your patients. Now about vitamin D. So to achieve a vitamin D of above 30, how much vitamin D is required? So for infants, toddlers, for children, as well as for adults, the treatment dose really doesn't change. The treatment dose for everyone is 60,000 IU 60,000 IU orally per week for 6 to 8 weeks. Okay, so that's the generally vitamin D that is required for treatment of deficiency of vitamin D. Now, if you want to give a daily dose of vitamin D for maintenance, then for infants and toddlers, it is around 400 to 1000 IU per day. For children, again, it is 600 to 1000 IU per day. And for obese individuals, so if you have adults, it is 60,000 per week for 8 weeks. Maintenance is 1,500 to 2,000 IU per day. And for obese person, so we have to understand that vitamin D is a fat soluble vitamin. Obese have a very high requirement of vitamin D, so they require a higher dose. So 60,000 IU per week for 12 weeks is what they'll require as a treatment dose. And for maintenance, again, they'll require a slightly higher dose. Now we need to understand that these maintenance requirements are what have been proposed by the US Endocrine Society. And what ICMR tells you is just 400 IU per day. So what is the logical way to go about it? When you take 400 IU per day, you do not reach the 30 target. So what we generally recommend to our patients is that they should be taking around 1000 IU of vitamin D from the supplements, okay, which they can also take it in the form of a 60,000 per month. So initially they take it weekly for 8 weeks, and thereafter they can keep on taking 60,000 IU per month. That is a good enough maintenance dose, okay, and that will help you to reach this and maintain your level at beyond 30. So what about intramuscular vitamin D? Now, many of us use intramuscular Arakitol or other intramuscular preparations. What happens with those? So this is a study which is comparing the oral versus the injectable form. Okay, and if you see, so when you give, so in this study, orally 60K was given weekly for 6 weeks, and so not even a 6 lakh, a 3 lakh injection of Arakitol was given. Okay, and then what happened? So equivalent doses. So 60,000 per week for 6 weeks makes around 3,600 or so. 30,600 or so. And here what you're giving is 3 lakhs. So almost the same amount, but one is given orally and the other is given intramuscularly. And what happens is that at the end of 6 weeks, you have equal values with both the treatment, but after 6 weeks, the intramuscular injection, the values just keep on going, increasing and increasing, while the oral values fall. So what this means is that oral values, you should always give maintenance dosages. Otherwise, your values may fall down. And when you want to give injections, you should not repeat injections more frequently, because you need to understand that even with a 3 lakh injection, the values are reaching very high. And if you repeat the injection every week or every 15 days, these patients land up with vitamin D toxicity. So you should not repeat an Arachidol injection earlier than say 6 months. I mean, it's not required. Okay. So what is the level at which you call it as vitamin D toxicity? So any level more than 100, okay, then that is considered as toxicity, and more than 150 is definitely toxicity. So if value is below 100, it's okay, but we do not want the value to go beyond 100. And generally the upper tolerable limit of intake is around 4000 IU per day. Now, this is a paper published from India, which is talking about vitamin D toxicity. So if you see, there are 15 or 16 cases who had vitamin D toxicity, and look at their vitamin D values. They were very high. So more than 160, 160, 300, one value of 1000 and so. And generally these patients can have hypercalcemia, poor appetite, and they can land up into ICU. And if you look at all these patients, almost all except 3, all of them had vitamin D toxicity because of frequent IM injections. So frequent IM injections is going to land them with toxicity, not the oral preparations. Now, those who had toxicity with oral preparations, they took weird dosages. So if you see this patient was taking 4 times a week for 3 months, 60K. So rather than taking it weekly, the patient was taking 4 dosages per week for 3 months. Then again here, this patient misunderstood. The patient must have been told to take it weekly for 2 months. The patient took it daily for 2 months. And here again, daily for 2 months. So such patients who take higher dosages with oral may land up with toxicity. But the most common is intramuscular injections, which lead to toxicity of vitamin D. So other thing is about the use of active vitamin D. So whenever you prescribe a patient on calcium vitamin D supplement, always read what that tablet is containing. See, there are multiple preparations of vitamin D and calcium. Some preparations contain active vitamin D. What do I mean by active vitamin D is a calcitriol. So what I told you, the inactive vitamin D, that is called as cholecalciferol. Okay, so cholecalciferol doesn't give rise to any side effects even if you continue to give it in the long run. So if our patient is taking a vitamin D 60K every month, lifelong, the patient is not going to land up with vitamin D toxicity, or the patient is not going to get any renal calcium stones or any cardiovascular problem, nothing of that sort. But if your patient is taking active vitamin D, so suppose example, there are, so Gemcal and Gemcal D3. Now these are 2 common preparations which are used. Gemcal contains calcitriol, while as Gemcal D3 contains cholecalciferol. So if your patient takes Gemcal, that is an active vitamin D, continuously, then what happens is that these patients can land up with hypercalciuria and renal calcium stones. But if the patient is taking Gemcal D3, which is an inactive form, then chances of that happening are low. So there is no risk of hypercalciuria or renal stones with that. So it is important to understand. So what is the correct tablet to be given in a postmenopausal osteoporosis patient? We should understand that. Where do we require active vitamin D? Active vitamin D is required in very few scenarios. So where should we use a calcitriol containing preparation? We should use it in a CKD patient, because that patient does not have the step for activation. His kidneys have failed. He cannot activate the vitamin D. There are some patients who have a vitamin D deficiency or a vitamin D resistant form of rickets. VDDR is what we call them. They have a deficiency in that enzyme required for activation. There are patients who have liver disease who cannot then again activate. So such patients should be on active vitamin D. Rest all patients, you need not give them active vitamin D. And as I've told you, active vitamin D, if given for long term, can cause hypercalciuria, hypercalcemia, and there is no added benefit over our other vitamin D preparations. Now coming to sunlight exposure. So this is a very myth. I don't know how it has spread, but it is a very common myth. Sakalcha kobra un changla ahe. So that's not the fact when it comes to vitamin D. vitamin D, the rays of the sunlight, okay, they have to penetrate the whatever the UV rays and everything, they have to penetrate the Earth's atmosphere. They have to penetrate it at such a degree, and they have to reach us for us to form vitamin D, and that will happen only after 11 a.m. Okay, so it's actually the mid morning or the mid afternoon sun that is important for making vitamin D. Okay, and all the factors, so where you are, what clothes you are wearing, how dark you are, what is the pollution in your city, all that is going to decide how much vitamin D your skin makes. Okay, so generally the timing is 10 a.m. to 2 p.m. You should expose your arms, face, neck and legs at least for a period of 30 minutes, okay, to make vitamin D. But we need to understand, so suppose if it is cloudy, okay, outside there is a rain, it's raining, or then you will not make vitamin D. If even if, so you are sitting in the inside in the, and there's a glass partition, the sun rays cannot penetrate the glass partition. So I mean the rays which are required for vitamin D cannot penetrate that glass partition. So you will not make vitamin D if you're sitting inside. Okay, and how much area is exposed, again that matters. So if you're I mean many in India are, we cover ourselves and we are afraid of getting dark and all that. And so if we are going to wear all this such kind of clothes, we will not make vitamin D. And because of this, the sunlight remains a very variable source of vitamin D. So what we really emphasize is that taking supplements is the best option, mainly for sedentary workers. Now, those who are manual laborers and who are going to be out in the sunlight, it's different for them. But for all the other class of our people who are working in the offices, who are inside, and they should be taking vitamin D from a supplement. So this study was done in Pune. Okay, so this is from Pune, and it was seen as to how much sunlight is required to make vitamin D. So what was seen is that in urban Indian men, more than 1 hour is required to keep vitamin D beyond 20. So this is nanomole. The range that I told you is, I mean, what we want to remember is nanogram per ml. So that is 20. So if you want to reach a level beyond 20, you require 1 hour of sunlight daily. And if you want to keep the level of above 30, you will need more than 2 hours of sunlight daily. Now, this may not be really practicable for everyone, okay? But those who can, so they can rely on sunlight with 1 hour and 2 hours. So what about fortification? So do we have foods which are fortified with vitamins in India? So yes, there are certain brands which are available. So like, for example, Britannia biscuits and all sometimes contains vitamin D. Then Fortune oil we know can be fortified with A and D. Then there could be Amul milk and all those can be fortified with vitamin A and D. But you need to understand that these are levels may not be sufficient for us, and the levels are really not universal. I mean, we don't and we don't recommend that you keep on having biscuits to make vitamin D. So that doesn't really happen. So the food fortification in India as of now is not going to work. So we need to rely on supplements for vitamin D supplementation. So to summarize till now, vitamin D deficiency is prevalent in India, and we usually treat it for skeletal benefit. Extraskeletal benefits do exist, but there is not enough evidence for the same. Most patients, as a rough guideline, you should remember that they should receive 1000 to 2000 IU per day. So how do you achieve this? If you have a patient who's come to you and the patient says that I have bony pains, and the patient is having a muscle ache, and you suspect that the patient could be having vitamin D deficiency. Now, doing a vitamin D level is going to cost you a lot. And if the patient is not affording, rather than doing a value, you can directly start the patient on vitamin D oral. Okay, so you will not go wrong. You will not do toxicity by giving an oral dose of per week of 60K for 8 weeks, and thereafter 60K once a month. Okay, but if your patient is saying that no, I have already taken an injection, I have taken some injection from some doctor, I don't know what it was, Or the patient might tell you that, no, I have taken vitamin D in the past, I remember, but I don't know for how many weeks I took it. I might not have completed the course, and so on and so forth. So if you're not sure whether the patient has really taken, or whether the patient, you are afraid that you might land this patient into toxicity, then you can do a vitamin D level. But for all other practical purposes, you can directly start with the treatment without a vitamin D level if you're giving it orally. If you're going to give it intramuscularly, then I would suggest doing a level, because you don't want this patient to land up with toxicity. And avoid frequent intramuscular injections. For vitamin D, frequent injections are not required. Once in 6 months to once in a year also is more than sufficient. One injection once in a year is more than sufficient. So now coming to the second part of my talk, that is, I'm going to talk about PTH hormone. So parathyroid hormone, we know, is a hormone gets secreted from the parathyroid glands. There are these 4 parathyroid glands. So around the thyroid, we have these 4 parathyroids which secrete PTH. What does PTH do? PTH has action at the level of bone. It has got action at the level of kidney. So the direct actions of PTH at the level of bone, from bones, it releases the calcium. Okay, from kidney, it reduces the reabsorption of calcium. And that is how the blood calcium increases. Also, PTH has got an effect in the vitamin D pathway also, and there also PTH has got value. Okay, so when it comes to high PTH, then you need to understand that not all high PTH is primary hyperparathyroidism. So I get many patients where the doctor does a PTH value but doesn't do a calcium value. So there it doesn't really make any sense. I mean, unless and until you do a calcium phosphorus, you should not go for PTH. Don't do a PTH directly. So if your calcium is high and your PTH is high, not suppressed, then you should think of primary hyperpara or a tertiary hyperpara. Okay, what is tertiary hyperpara? So those patients who have long-standing secondary hyperparathyroidism, that means a patient has a kidney problem, and because of kidney problem, they have less calcium. And in that, because of low calcium, the PTH rises. So that is called as secondary hyperparathyroidism. And if this chronic kidney failure patients continue to have low calcium for years together, which doesn't get treated adequately, then 1 out of these 4 parathyroid glands can actually develop an adenoma. And this secondary can then get converted to tertiary. So that is what we mean by tertiary hyperparathyroidism. Okay, primary hyperparathyroidism means that there is a adenoma or a tumor in one of those, or in all of those in all of those parathyroid glands, because of which there is a high calcium level. So unless and until you have a high calcium, you are not going to actually look at PTH. Or if you have got a low calcium, only then you're going to look at PTH. Don't look at PTH without knowing as to what the calcium and phosphorus is. So what are the different manifestations in which a hyperparathyroidism patient presents? So hyperparathyroidism patient can have stones. So they can have renal calculi. Okay, they can have problems with bones, that they can have fractures. They can have OFCs or bone cyst, as can be seen in the X-rays. Okay, they can have psychic moans. So that means they can have lethargy, fatigue, depression, memory loss, stupor, coma. They can have abdominal pain, that is what we call as abdominal groans. So because of constipation, indigestion, peptic ulcer, and pancreatitis. And they can have certain other manifestations also. So this is an easy mnemonic to remember what the symptoms of primary hyperparathyroidism are: stones, bones, moans, and groans. So this is how we remember as to what the symptoms of hyperparathyroidism can be. Now coming to a case. So this is a 32-year-old female. She is a mother of 4, and she has had frequent bone problems, and she has complaining of bony pains, and she says that she had suffered a fracture of humerus around 4 years ago, and she says that she also has certain bony swellings somewhere, and she's complaining of proximal muscle weakness. And during investigation, what was seen as her calcium is 10.1. Any calcium which is more than 10, you should repeat it again. Generally, with our good assays, a calcium between 8.5 to 10 is considered as normal. 8 to 8.5 and 10 to 10.5 or 10.8 is considered as a gray zone. So this calcium was slightly high, but look at the phosphorus. The phosphorus is very low. We want the phosphorus to be beyond 2.5. So her phosphorus was low and her alkaline phosphatase was elevated and her parathyroid hormone was sky high. It was more than 2000. So very high parathyroid hormone with a higher calcium. So here we are suspecting that she could be having a primary hyperparathyroidism, and in hyperparathyroidism there is low phosphorus. So when we do a X-ray radiology of the bones, we can see that there are these OFCs, osteitis fibrosa cystica. Okay, there are these pseudo fractures. Again, the cyst here, lytic lesions present in the skull X-ray. Okay, so all these are pointing towards that her bones are weak. Then there is a subperiosteal resorption seen in the X-ray of the hands. This is a OFC, a bony cyst kind of a thing. So all this is pointing towards PHPT. So then for PHPT, we do a nuclear scan. It is called a SESTAMIBI scan. And then in this SESTAMIBI scan, there is this parathyroid adenoma, which is visualized. So this patient basically had a primary hyperparathyroidism. And if this patient then underwent surgery and she got cured. Now coming to another patient. So another patient had a 30-year-old male. Complaints were bony pains and he was also complaining of teeth loss. Okay, so they were falling of teeth, adult patient. And his calcium was high, phosphorus was low, parathyroid hormone was high. So again, he was biochemically fitting into primary hyperparathyroidism. So again, we'd go ahead and did this SESTAMIBI scan. So after doing this SESTAMIBI scan, this parathyroid adenoma was visualized. So this patient underwent surgery for this adenoma. So this adenoma surgery he underwent, but post-operative also, if you see, his calcium is still remaining high. So what could be the problem here? So you have removed this surgery, the adenoma, but still your calcium is high. So basically, when we went into the family history of this patient, here he is standing with his father. His father also had history of hypercalcemia, kidney stones, and polycystic kidneys. He never underwent any evaluation for this kidney stones. He refused to do any surgery, the father. Okay, but the father gave the history that even the patient's grandfather also had renal stones and he died because of kidney failure only. So this is a patient who is having a familial hyperparathyroidism. So his father is also having and his grandfather is also having. And he also had this jaw tumor, and because of which he was losing teeth. So basically, this is a different kind of syndrome. It is called as a hyperparathyroidism jaw tumor syndrome. And these patients have got multiple parathyroid adenomas. So that means they don't have adenoma in only one gland. They can have adenoma in 2 or 3 glands. So this patient had one more adenoma. So both the adenomas were again removed. So he underwent a second surgery and then he was cured. Okay. So now coming to one more patient. So here you have a 30-year-old female who is complaining of hematemesis. And for hematemesis, you do a scopy. The scopy shows severe gastritis. And also she has high calcium, low phosphorus, high PTH, again fitting into primary hyperparathyroidism. So you again do a parathyroid scan, the SESTAMIBI scan, and that scan shows that there is this parathyroid adenoma, which is seen even on the CT. Okay, but then you have to remember she has gastritis and she had irregular menses and her prolactin levels were very high. And so her MRI was also done, and that MRI showed that she had pituitary adenoma. So she had prolactinoma, she had hyperparathyroidism, and she had gastritis, probably due to gastrinoma. So this patient is fitting into MEN1 syndrome or multiple endocrine neoplasia type 1. And these patients then, the MEN1 patients, they have multiple gland affection. They don't have adenoma in one gland. They have affection of all the 4 glands. And ultimately they require surgery of 2, 3 or 4 at a time. Okay. So now for those patients of yours who have high creatinine, so suppose the creatinine is 5 or 6, the patient may or may not be on dialysis and the PTH values are high. So that is what we call as secondary hyperparathyroidism due to chronic kidney disease. Then these patients should be managed by a nephrologist. There is not much role of endocrinologist here. If the secondary patient turns into a tertiary, then again the endocrinologist comes into picture. But if it is secondary, the major role is of a nephrologist. Now coming to the other end of the spectrum, that is hypoparathyroidism. So I have talked about hyper, that means PTH value is high. Now I'm talking about low PTH. So when what will happen because of low PTH, there is low calcium and high phosphorus. So unless and until your calcium is low or your phosphorus is high, you will not do a PTH. And if you have low calcium and high phosphorus and you do a PTH and it turns out to be low or not detectable, then it will fall into hypoparathyroidism. This is a very rare condition to happen, and it generally happens after, say, thyroid surgery. If the surgeon inadvertently removes the parathyroids along with the thyroid, or it can be autoimmune, or it could be idiopathic hypopara, or it could be a familial hypopara. So I was asked this question as to how do you approach a patient of hypocalcemia. First, we need to understand is that the patients who are presenting to you to your OPD. So suppose if the patient is hyperventilating, you get a patient who's very much anxious, panicky, and is hyperventilating all the while, and then you do a calcium level at that point of time, you can have a falsely low calcium, okay, because of the washout, the CO2 washout and everything, and because of the alkalosis, you can get a low calcium value. So measure a calcium value when the patient is calm, so that you will come to know what is exactly the calcium. So as I have told you, if the patient is having low calcium, the second thing to do is to look for phosphorus. Phosphorus has to be done in every patient. So phosphorus, if it is high or if it is low, then there are different conditions which exist. Okay, so if you have hypocalcemia with a high phosphorus and PTH is normal or low, then this patient is more likely to have hypoparathyroidism. If you have high phosphorus but PTH is also high, then they have a disease called as PTH resistance. If they have low calcium as well as low phosphorus, then they're more likely to have any other, say, malabsorption or CKD kind of problems. Okay, so there are these different causes which can happen depending upon what phosphorus you have and what is the PTH value. Then what are looking at the vitamin D and the 125 hydroxy vitamin D, there could be different types of VDDR. So this I won't go into the details, but here I want to emphasize to you one point is that look at the phosphorus. After calcium, don't directly jump to PTH value, look at the phosphorus value and then you can decide. Okay, so for treatment of hypocalcemia, if it is a acute hypocalcemia, then they generally require intravenous calcium gluconate. We give them a drip, okay, up to 1000 milligrams in 24 hours can be given, and then we start them on oral calcium and active vitamin D. So here again comes the role of calcitriol. So acute hypocalcemia, many a times they require active vitamin D as a treatment for short term till their calcium level normalizes. Suppose if the patient is having chronic hypocalcemia, okay, the patient is not having any seizures, the patient is not having any active tetany, then you can manage this patient on OPD basis with 1 to 2 grams of elemental calcium per day and active vitamin D metabolites, that is calcitriol initially, and then you can follow these patients up. If the patients are hypoparathyroidism, they require calcitriol for the rest of their life. So depending upon the cause, then you'll have to decide what kind of calcium and what kind of vitamin D to be given. Now, when to order a PTH, I have told you only after initial biochemistry, that is you have calcium, phosphorus, albumin, alkaline phosphatase, creatinine, and then you look at what the PTH is. Do not directly jump on PTH. PTH is a very fragile assay. Okay, so your lab should be near to you. If you want to collect it in your center clinic and then send it to the lab, you will have to maintain a cold chain. Otherwise, you can get a falsely low value of PTH. So it is very, very, very important to transfer the sample correctly. Then so the two common scenarios are hypocalcemia and hypercalcemia, and in both these scenarios, after phosphorus, you can do a PTH value. So both the things, what will help you is what is the phosphorus. So please always order a phosphorus when you're ordering calcium. So now coming to jumping, so I've talked about vitamin D, I have talked about PTH, calcium, phosphorus. Now I am going to another case scenario, that is osteoporosis. Okay, so now 55-year-old female, she is postmenopausal for the past 3 years, and she fell down from two-wheeler and she sustained a fracture of tibia fibula. And then she basically goes to orthopedic for that fracture, whatever casting and surgery, whatever gets done. But she has this question to her ortho that why did I get this fracture? Are my bones weak? She wants to rule out osteoporosis. So then comes the question, now how do you diagnose osteoporosis? We know that it is diagnosed on the basis of a bone mineral density. Bone mineral density, or DEXA scan as we call it. So DEXA scan, then which machine should be used? What are the different sites for which you should study the bone density? How do you prepare the patient? So these are the different peripheral DEXAs, central DEXAs, or QCT machines that you have for diagnosing osteoporosis. Whatever machines that we have in the camps, health camps, the peripheral DEXA ones, the one where, you know, they tell you to put a foot there and look at the bone density, those are not really accurate. What is the most accurate is this central DEXA, where the patient lies down on this machine and then they measure their bone mineral density. So central DEXA is the most accurate thing, and that is the one which we should all be doing. So which site? We generally tell the patient to do DEXA or a bone mineral density for PA spine, okay, the lumbar spine and the hip. And forearm BMD, that is distal radius BMD, is also done in certain circumstances. When we get a DEXA report, then generally these are the two scores which are written in that report, a T score and a Z score. T score talks about what is the comparative BMD, or how the bones of that patient are as compared to a young adult. Okay, so T score compares that person with a young adult, and Z score compares the person with a person of his equal age matched BMD. So those who are post-menopausal, we look at their T scores, and those who are before menopause or young males, we look at their Z scores or Z score as we call it. So depending upon what the T score is, then you can classify whether the patient is normal, osteopenia or osteoporosis, or severe osteoporosis. Okay, and this is how generally a report looks like. So there will be an X-ray, there will be this different T scores and Z scores written, and then we have to look at where on the graph this patient's that BMD is lying, and accordingly then we can reach a conclusion. We never go by what the interpretation that the lab gives us. We have to look at this raw data, we have to look at all this individual data, and then we arrive at the conclusion. Okay, so the X-rays and all these radiographs are also important. So machine is important. So suppose if a person has once done a DEXA scan on a hologic machine, okay, and the next time he goes to some other machine and does it from a GE lunar, then we have to understand that we cannot compare the two reports. There's slight difference in between the two machines. So they should be doing repeat DEXA scans always on the same machine and not on different machines. Okay. Before labeling osteoporosis, always rule out secondary causes and rule out osteomalacia. So if I have vitamin D deficiency, very severe vitamin D deficiency, I have low calcium, and I go and do a DEXA scan, then I can be wrongly diagnosed as having osteoporosis, because DEXA scan cannot differentiate osteomalacia and osteoporosis. And we need to understand that treatment for both these conditions is very different. So before we label someone as osteoporosis, we need to rule out secondary causes and we need to rule out osteomalacia. There is multiple causes of secondary osteoporosis like hypogonadism, hyperparathyroidism, hyperthyroidism, Cushing syndrome, certain drugs, then some GI problems, then some bone marrow related problems. So all these things need to be ruled out. We also have a FRAC score, where when the patient comes to us, we put all these data. What is the age, sex, weight, previous fracture history, parental history, smoking, whether the patient is on steroids, and ultimately we get what is the risk of this patient developing this fracture. We have this for India also. So this risk assessment should be done for those patients who have multiple fractures, and for them where the DEXA alone is not sufficient. Now coming to this one more patient. So this is a 40-year-old female. She is having vague body aches, weakness, and she says that my mother had suffered this fracture neck femur, and then she ultimately died because of that fracture neck femur. She was bedridden. So she is very much worried about bone fractures. And she comes to you and she tells you that no, माझ्या आईला हे सगळं असं झालं होतं, मला फार काळजी वाटते की मला पण असं सगळं होईल, तर माझी हाडं तुम्ही तपासा, माझा हाडांचं स्कॅन करा, माझी हाडं माझे किती स्ट्रॉंग आहेत, किती वीक आहेत ते मला सांगा. So what do you recommend? So in this patient who is 40-year-old female, do you do a DEXA scan? So the answer is no. I mean, DEXA scan is not required in a 40-year-old female patient. At the most, you can do what I told you, the FRAX scoring. You can calculate the FRAX scoring and then tell this patient that what is your risk of this bones and whatever fractures developing. When do we do a DEXA scan? DEXA scan should be done in a post-menopausal women or men who are age 70 and older, or who have adults who have had a fragility fracture. So they were just walking, पाय मुरगळला, fracture झाला, or they just fell from a height which is less than their standing height. That is what we call as a fragility fracture. म्हणजे somewhere where the fracture, you don't expect the patient to sustain a fracture. So suppose, for example, you're walking and पाय मुरगळला, we don't expect fracture to happen for everyone. So if there's a fracture happening, then that means your bones are weak. So that is what we call as a fragility fracture. So the fragility fracture has happened, or the patient has, say, rheumatoid arthritis, or the patient is taking steroids, or the patient is taking anti-epileptic drugs for a long period of time. So then whatever be the age, then we can do a DEXA scan. But otherwise, for a healthy person who just wants to do a DEXA scan for screening, it's not really required. And after osteoporosis gets detected, we tell the patient that you should not smoke, you should not drink, you should have good amount of exercise. Both aerobic as well as anaerobic exercise should be done, and you should have a healthy diet. You should have calcium, vitamin D enriched diet, and that will keep your bones strong. So lifestyle measures are important. There are different kinds of treatment for osteoporosis. I'm not going to go into the details of that same, but there are two major treatment for osteoporosis. One where we inhibit the osteoclast, and the second where we stimulate the osteoblast. So osteoblast is a cell which forms the bone, and clast is a cell which degrades the bone. So if you stop the degradation and increase the formation, then you can prevent the fractures. Sorry. So bisphosphonates are anti-osteoclastic. So they can be either oral or intravenous once in a year. Intravenous bisphosphonates can give rise to acute phase reaction. So patients who sometimes we tell these patients, you know, intravenous zolendronate and all that, and we tell them that go take it to your nearby hospital or take it in a nearby center. And we generally warn these patients that after these injections, for the next 3 to 4 days, they can develop fever, they can develop joint pains. This is what we call as acute phase reaction. So there's nothing to be worried if this happens. Then teriparatide is one drug which is routinely prescribed by orthopedics, but is not very much required. It's required only in few scenarios where there is severe osteoporosis. That means the T-scores are below -3, or there is a fragility fracture, or they are refractory for bisphosphonates, are unable to tolerate the bisphosphonates. And whenever we give teriparatide, we have to continue it for 2 years. There's no point in giving teriparatide for 3 months and then stopping. It will be of no use. So you should continue teriparatide for at least 2 years, and after 2 years you can switch over to other therapies. So osteoporosis is very common. I mean, so you hear about diabetes, you hear about thyroid. How common is diabetes? 1 in 10. How common is thyroid? 1 in 10. How common is osteoporosis? 1 out of 2 women more than 50 years. So if a woman is more than 50 years, 50% of these women are going to have osteoporosis. So 1 out of 2 women have osteoporosis who are more than 50 years. 1 out of 4 men who are more than the age of 50 have osteoporosis. So unless and until you diagnose osteoporosis, you cannot start the treatment. And if you cannot start the treatment, what happens is that these patients land up with fractures and they land up with morbidity. So it is very important to diagnose it. So suspect it more often. Do DEXA scan in patients who are more than 50 years of age. Okay. Madam, do we have time for 2 more cases?
Yes, madam.
Okay, right. So I'll hurry up. So these are two interesting cases which I just wanted to put up. So this is this was basically a 32-year-old farmer, and he was running from pillar to post. First, he went to neurologist, saying that my both the lower limbs are weak, I'm bedridden. The neurologist did a AMG, NCV, all was normal. Then the neurologist did an MRI. MRI showed that there was bilateral avascular necrosis of neck of femur. So because of that MRI report, then the neurologist transferred the patient to an orthopedician. So our orthopedician said that, okay, now I'm going to replace both your hips, and the patient was posted for hip transplant. And before that, they generally do the lab, and the lab, in that lab, anesthetist found that there was very low phosphorus. The phosphorus was 0.7. And so the anesthetist basically sent it to an endocrinologist saying that, no, first get an endocrinology fitness. Your phosphorus is very low. There is some problem. So then we came into picture, and then when we saw calcium was normal, but the phosphorus was very low, vitamin D was very low. And look, even if the vitamin D was very low, PTH was not very high. So there is something going wrong in this patient. And if you look at the radiology, all his bones were weak. Here you can see there is a pseudo fracture there here in the tibia. So all these problems this patient had. So because the patient had low vitamin D, first we gave him vitamin D. So correction of vitamin D was done. And 3 weeks post correction of vitamin D, so giving weekly dosages every week for 8 weeks, still the phosphorus is low. So there, that means the patient is having something beyond vitamin D deficiency. So such patients are then worked up. There are different steps that we do. We look at the urinary phosphorus studies and other lab parameters like venous blood gas. We look at the urine routine. And then we do an FGF23. FGF23 is basically one more hormone. And this FGF23 in this patient was very high. So this patient, then that means this patient is having a hormone FGF23, which is coming from somewhere, and that is causing low phosphorus. Okay, so to look as to from where this FGF23 was coming, we did a FDG PET. And this FDG PET, we found that he had a tumor here in the right thigh. Okay, and this tumor, then the MRI was done, and then the angiogram was done, and then this tumor was actually removed. So post surgery, the patient's phosphorus went up, FGF23 came down. So, and the patient started